So your desktop is not too bad.
Oh, you're seeing my desktop. My goodness. You're not supposed to. Okay. Oh, a lot of secrets there.
Oh yeah. Okay. Let me quickly take a screenshot.
Oh, okay.
No, I'm
And
just
then
joking. You
sell it
can.
for some sensitive material. No,
Okay.
no,
Oh,
you can
there is
see the.
sensitive material. Okay. Interesting.
No, no, no. So it
But
is full of
you're
rubbish.
still sharing it.
Okay, sorry. So I'll stop. Should I stop? No, in the sense, it's nothing objectionable. It's
No, I'm just joking. But
it
you can just stop
just,
sharing for some time.
yeah, yeah. Sorry, I didn't realize it. 1 second, I'll stop sharing. Okay, that's better. No, no, it's okay. Just that I give some. It's very untidy. Okay, so I can see two of them from MSAI.
So
Three,
there are,
four,
yeah,
five.
people from all over
Yeah.
the country in various places.
Okay, so okay, great. So people are already joined or joining or joined. Okay,
Yeah.
38. Okay. Saturday evening, you're
No, they
attending
asked for
something
this
like this.
time because that's when they have some time, free to attend.
Okay,
So yesterday we had about, I think, almost 70 something.
okay,
Uh, so I guess they'll join.
right.
What time do you have to leave, Dr. Nagaraj? You have to go soon?
Uh, well, as in, I'm okay till 5:45.
No, we'll be done before that.
Yeah.
So up to you, Pujita, when do you want to begin?
We can wait for 2 more minutes and start.
Okay.
And you've been having a small Q&A, right? At the end of every talk?
Yes.
Okay. And you open the mics? How do you do it? Through the
We ask for questions in the chat,
chat.
and we can even open the mic. That's
Okay.
Ma'am, I guess we can start now.
yes.
Should I share my screen and start right away?
Yes. 2 2 minutes, sir.
Okay.
Good morning, good evening, everyone. I am Pujita Ishwaroju, currently serving as a National Public Health Officer alongside with Vansh Dirwani. And we are delighted to welcome all of you joining us on Zoom and on our live stream for the day 2 of our Introduction to Organ Donation webinar. For those joining us for the first time, the Medical Student Association of India is the country's largest student-led organization of future healthcare professionals affiliated globally with the IFMSA. Within MSAI, the Standing Committee on Public Health is dedicated to bring healthcare divides by empowering medical students to lead evidence-based public health advocacy, grassroots education, and community outreach across India. We had a great first day yesterday with Organ India. We are here back to continuing the great enthusiasm and learnings. Let's begin with our first session for today, passing on to Sunya ma'am.
Hi, everybody. I'd like to now call Dr. Sanjay Nagral. He is a surgeon based in Mumbai whose practice focuses on hepatopancreatobiliary surgery and liver transplantation. He's currently the director of the Department of Surgical Gastroenterology at Jaslok Hospital and Research Center in Mumbai. Dr. Nagral trained at the GS Medical College and KEM Hospital, where he also held an academic position as Associate Professor of Surgery and went on to undertake fellowships at King's College Hospital and the Royal Free Hospital in London. He has published extensively and has made significant contributions not only to surgery and transplantation, but also to medical ethics and health policy. He is the publisher of the Indian Journal of Medical Ethics and chairperson of the Forum for Medical Ethics. He was co-chair at the Executive Council of the Declaration of Istanbul Custodian Group, a global organization working on transplantation ethics for the years 2021 and 2024. He currently serves on the expert advisory panel on donation and transplantation of the WHO. He also regularly writes in the press on public health in the national media. We are delighted to have Dr. Nagral with us today and very excited to hear from you. Your topic is Who Gives, Who Lives? Ethical Dilemmas in Organ Transplantation.
Thank you, Sunaina. I presume you can hear me?
Yes.
Okay, so thank you very much and delighted to be here. And before we started, I was talking to some of the office bearers of the MSAI, and I reminded them that I was a medical student not many years ago. And I also asked them whether they are Gen Z, and one of them actually said no. And I said, why are you not Gen Z? And I said, anyway, even if you're not, you should be proud to be Gen Z. It's probably after long that I'm talking to Gen Z and medical students. We normally talk to slightly older people, and it's great to be amongst all of you. So as you can see, the title of my talk is around ethics, and ethics is normally a slightly boring topic. It sort of conjures up visions of morality, etc. But I hope to engage you in a slightly different way, as in not really talk too much about the theory, but how does it apply to the day-to-day challenges in transplantation? This is just for you to know why I am giving this talk, because of this background that I've had. Okay, so organ transplantation always is looked at as drama and adventure. I mean, if you look at Indian, even the media space, and even if you look at culture, you will have so many books, movies, and of course, news. The tragedy, though, or the sad part, though, is that transplantation actually has both sides, and unfortunately, we have to understand both sides. One is, of course, the amazing science that it represents. It represents a great example of human solidarity. You can't probably find a better example when individuals donate organs to unknown people. Uh, uh, but also, unfortunately, it is an example of commerce, not just commerce, but power, the use of coercion, power, social hierarchy, to both coerce or induce people to donate a part of their body. So, therefore, it has this dichotomy, which is very unique. I must start, and probably somebody else has brought this up yesterday, that that's exactly what makes transplantation very different from healthcare, technology, science, everything else, because what it needs is somebody to donate an organ. Without an organ, there is no transplantation. So I think that's what actually gives it both the sense of drama, but also some of the ethical challenges. And this is actually what I just said. Uh, of course, one must start with the acknowledgement that it saves lives, it improves the quality of life significantly. So what's happened, and it's not difficult to understand that the demand for organs is huge. The number of donors is obviously much less. In my view, this gap is just widening, because with the success of transplantation, more and more people will go in for transplant, and it's unlike to be ever bridged. In our lifetime, we are not going to see this gap being bridged. And in fact, any country planning well must plan for preventing transplantation, because we are seeing a huge epidemic of non-communicable diseases, and transplantation is never going to meet the needs of those with kidney failure, liver failure, etc. As I said, that it is actually also an outstanding example of both science and solidarity. But I think we must also understand, as a prelude to what I'm going to share with you, and those are some of the ethical dilemmas, is what is unique to transplantation. A repetition of what I said, a massive demand supply gap, a desperate recipient whose only hope is to get an organ from another human being as of now. What also we need to understand is that when a deceased donor, and you heard that term probably yesterday, families who donate the organs after a loved one has passed away, largely in the context of brainstem death, that organ is actually a public good. Now, what does a public good mean? That it's an organ donated to society, and society and the state has to decide what is the best way to use that organ. So it pushes a huge collective responsibility on all of us. The other challenge is that when you have a live donor on live donation, you have a healthy person undergoing an operation. A person who doesn't need that operation, a donor does not need, a live donor does not need that operation. So it's a unique surgery which has a small but definite risk. So again, a very, very unique situation. And finally, of course, therefore, all this is fertile ground for inducement, coercion, and the use of power. Donation also is actually a social experiment. And therefore, it has lots of public health dimensions. It needs social conditions. It needs solidarity from one human being to another. It has to cut across barriers. A lot of cultural values around the idea of death get tested. It's also about the citizens' trust in the healthcare system and the transplantation system, because if they are going to make a huge go ahead with a huge act like donating somebody's organs, usually it means they need to be sure that it's a transparent, fair system that they are donating to. And finally, there is the whole issue of reciprocity. Citizens of any country, how do they develop trust in its healthcare? By reciprocity. So when they get their demands or their healthcare needs sorted out in time, in the right manner, in an accessible manner, they trust the system. And I think in India, this particular area is under severe strain. So as I said, there is, of course, the individual aspect to transplantation, but there is the public health dimension. There's also the whole issue of what does transplant do to cost effectiveness. So for example, in the kidney, and of course, Ashish is going to probably talk in detail about solid organ transplantation in the kidney, but it's a very cost effective measure, both in terms of saving money on dialysis, but to the individual to go back to a normal life, because it vastly improves life. So it's not just life-saving, but it has many other dimensions. But transplantation also has ripple effects. Besides the economic benefit, it hugely improves healthcare expertise across many departments. So a hospital which performs transplants, its expertise in other areas also indirectly will be put to test and will improve. Because transplantation makes huge demands on other departments. Finally, what transplantation does is also puts the lens on death, dying, end of life care, withdrawal of futile care, because countries to move towards disease donation have to really put in place policies around futility of care and therefore withdrawing care and therefore donating organs. I'm not going into that whole area. Probably it was explained yesterday. Now, so what's the global scenario? How are we doing? How is the world doing? Here's a snapshot of some figures. This is GODT. So this is 2024, 1,74,000 transplants. But India, we always say is third in numbers. But to be fair, when we talk about transplantation, we must talk about transplants per million population. Because obviously India is a big country. Therefore, we will do more of everything, not just transplants. We'll have more of everything. But it is transplants per million population that really tells us whether we are able to improve access for our citizens. It is an indicator of availability, accessibility to individual citizens rather than the total number of transplants. I just put a box there about who are the top 30 in terms of per million population. India is about number 70 or something like that in per million population transplantation. So the facts are they are all high income countries. Three are upper middle income. What is important to understand is that most of them have some form of universal health care. I'm not going to explain what universal health care is, but most of you, I'm sure, know it. Out of the 10 most populous countries of the world, only the US is in the top 30. So most populous countries of the world do not have a very good transplantation system in place, and accessibility is a big problem. And here's a look at who are the top 20 countries in the world in deceased donation numbers. And what you will again see is the per million population figure, PMP. Again, global north, universal healthcare except the US. Uruguay moves up because Uruguay has a strong universal healthcare. The point I'm making is that none of these countries have actually achieved high donation rates by just some kind of tweak of policy. It's a reflection of universal healthcare and therefore a huge trust in the system. Transplantation in the global south, which is where we are, these are some of the facts. I'll not read through each and every one. Suffice to say that many of these will impact on how we develop transplantation. But also what we are increasingly seeing is in the global south, that includes India and South Asia, there's an increasing presence of the private sector. Now, I'm not here to sort of expand on this issue, except to say that I think this makes some impact in both ways. The private sector drives transplantation, it drives expertise, but also it makes transplantation unaffordable. But not just that, but it also monetizes transplantation. And in a monetized system, the trust always is a problem. Incidentally, the global south, including India, continues to be one of the hotspots for organ trade. We don't have reliable data on whether organ trading has gone down over the years, but you will see every year sort of the media reporting on what are called as kidney scandals or scandals where foreigners are coming in and so on and so forth. So the challenge of the organ trade continues. Now, this you must have seen this slide yesterday many times, and probably it's repetitive. I just want to point out, though, that this law, the 1994 Act, did two things. One is it banned training in organs because it was a response essentially to the organ trade in India in the early 90s and the 80s. And it also legalized brainstem death, and all that probably has been discussed. So it was through a history of organ trade that India arrived at its later transplant journey. So this is a snapshot of India, again, because it has some relevance to what I'm going to talk about. So it's a very inequitable system. Uh, it's largely in the private sector, mainly living donors, and very non-informed across the country. And this is just again data from Noto showing severe inequity in terms of many aspects of transplantation in India, both geographical reach, etc. This is the paper. Ashish Sharma, who's here, is also a co-author. I just put up this chart here. It's an old chart to show you what it's relatively old data, but this is a snapshot of what largely still happens in India. But the arrow is on the public sector, so it's a very limited number that's being done in the public sector. It's probably more for kidneys, and of course, it's largely live donation. So one of the first questions which comes to the forefront from the area of ethics, and now one is talking of what is called distribution or distributive justice. And I'm just going to throw terms at you. I don't have the time to expand on any of these concepts. But when there is a deceased donor organ, whom do we give it to? Should we give it to the sickest, or should we give it to the person who's most likely to recover quickly from the operation, who's relatively less sick? Because the relatively less sick may respond better to the operation. So this is a debate. Should we give it to elderly people? What is old? When should we say no? Should a person who is 70 not get an organ, even if the person is dying? Should we invest more in the young? Should we give organs to those who have liver disease due to alcohol? They have sort of been alcoholics, we're addicts. Should we, into inverted commas, waste organs on alcoholics? So these have been some of the debates across the world from an ethics lens when it comes to allocation. Should we have the family members of the deceased donor decide whom to allocate the organ to? What if they say that we want to give an organ to certain types of people? We don't want to give it to the others. Should family members of those who have donated get priority for if they need a transplant in the future? So these are some of the sort of issues being discussed globally when it comes to allocation of organs. Yet another issue, which probably has been pointed out yesterday, maybe pointed out today. It seems that especially when it comes to the kidney in India, it is women who are donors. So what's happening here? Why do more women donate organs to men? It's wives to husbands. It's also daughters to parents. It's sisters. So what is this? Is this some kind of the caring gender? Is this an attempt to support the breadwinner? The male is often the breadwinner, etc. Although increasingly not true. Or is this family pressure? Is it a reflection of patriarchy? So this is another issue which is peculiarly a South Asian phenomenon, but has been intense scrutiny by those, especially who look at it from the social science lens. Here's another challenge for us from an ethics lens. Living donor liver transplant, huge numbers. India is doing huge numbers. I work in a hospital. We are a center which does it. But there is a risk to the donor. The risk is, of course, of any surgical complication, but unfortunately including potential death. And we don't know today, unfortunately, in India, how many people we have lost as live donors. We need good data, we need reporting, we need auditing. We need, of course, informed consent. And that comes to us from an ethics lens, that what are we telling the donors when we consent them? So therefore, the living donors, especially liver, kidney, much less. We now have a figure of 0.2 to 0.4% globally. What is the figure in India? We don't know, but I suspect that this figure is slightly high. So what it means is that 1 in 400 living donor liver transplant donors is going to die of the operation. And remember that this is a healthy person who has no reason to have an operation. Now, this is just a slide I picked up from another presentation of mine where I say that we typically talk of barriers to deceased donation. And I've said the seen and the unseen. So the seen are the obvious: lack of awareness, recognition, how we approach the family. I mean, you're going to hear a lot about this. But I think it is also about how we deal with end of life? What is our intensive care culture? What is the sort of futility? How do we withdraw support? How do our ICUs function? What is the capacity of the ICU? The domination of living donation, I think that is also pushing disease donation towards the background. But I think it is also, and I think I'm going to time and again come back to this theme, that transplantation, the cost, the involvement of big private sector hospitals, the transplantation for foreigners, what is this conveyed to ordinary citizens? And I think it is this image of transplantation that also makes an impact when we come to issues like what is the public response to donation. Okay, so here's the big debate. Here's the sort of, on one hand, the organ trade, but on the other hand, certain recent developments in the globe in terms of what is now the big debate of whether we should, in some form, compensate or even incentivize donation by some means, because we need donation. We need also to, in a sense, protect a donor, including financially protect a donor. So therefore, there's intense now discussion on this as to how do we do that. In India, there has been periodic debates on how do we support even deceased donor families. So there are many ideas here. So you, of course, remove the disincentives for the donor. So suppose a donor is going to lose their job or is going to lose pay. Can we compensate the donor? Does that mean compensation? Does that mean are we crossing the boundary? Can we give non-financial incentives to a donor if we don't think that financial incentive is a big idea, is a good idea? And of course, monetary incentives. And there is increasingly, and I'll come back to that in a minute, whether there can be a regulated market for donation. But we need to remember that money is coercion in another form. So in any society, monetary reward for an act, it is going to be picked up by those who need money desperately and the poor. So money is coercion. Money will mean upward mobility of organs from the poor to rich. So this is a fertile ground, again, for elite capture, for coercion, and for trading. But also, if one brings in the monetary angle for donation, one wonders what it will do to the otherwise idea that we promote of altruistic donation. So whenever we talk about families donating, we always talk about altruism. So how will it sit with monetary compensation or monetary incentivization is a big question, and the issue is not settled. So the organ trade continues. This is recently, 2 years back, Nepal, Kolkata. And this is the kind of news that keeps up coming. But I must say this, that when we talk about the organ trade in India, we tend to think that it is organ trade is in some small kitchen hospitals. But the unfortunate reality is that periodically, every few months, we find that even biggish hospitals, well-known hospitals, are caught out on this. And the way that they are being caught out is that there are authorization committees, which are the regulatory committees which are supposed to look at who the donor is and how the donor is donating. And again, I don't have the time to go into how this process works. Maybe somebody has looked at it. It seems that these committees time and again are hoodwinked. Whether they are hoodwinked or whether there is a sort of pass given to this, I'm not so sure. But I think that often it involves some degree of collusion from the health system. And therefore, I think this is a very serious matter, and it impacts also on the great solidarity, the great work that is being done by so many other institutions. And I think, therefore, I just bring this up to say that we have a responsibility to also clearly come out against those amongst us who continue to currently perform what are not just unethical acts, but probably even illegal acts. Just a quick look before I conclude on what the world is thinking on in terms of a regulated market. So there are countries in the world. Iran experimented with it, but now the US is seriously trying to move towards it, where you actually have a government controller system which is transparent, regulated, where money is given, not directly as money, but through in some other means. So the US is talking of tax cut vouchers. And therefore, you get young or healthy individuals as donors who could do with some tax cuts. And these will be donors who may not even be related to the recipient. So this kind of ideas are coming in. This issue is very much still under debate and not settled. A final slide or two. I think access is also an ethics issue. It's a policy issue, but it's an ethics issue because, clearly it's ethics on a grand scale. It's ethics on a public scale. So when we talk of access, and the transplantation community, of course, and all of us, we keep talking of access. How do we increase the organ pool? How do we increase brainstem death certification and donation? But I think clearly the reason to address the whole area of ethics, justice, the public health dimensions, our public image, credibility, transparency is because clearly it is the ethics justice framework which will finally determine public trust and which in turns will impacts on participation in donation. And country after country has gone through this experience. And therefore, you can even think of some policy tweaks. We tweak policies in terms of affirmative action, in education, in many other aspects of public life. So whether we can have policy tweaks where we promote the organs going to public sector, where we mandate costs in private sector. So people have written about this, and those of you who are interested can even look at some of these articles where they have said that we need to push the public sector. We cannot leave it to the whims of the market, because if we leave it to the whims of the market in healthcare, obviously there is a boom in the private sector and the private sector will dominate. So we need to do this. Okay, so closing thoughts. There's no question that transplantation is a gift of life. Many of my own patients, we have seen them coming out from near death. We have seen them flowering into very, very healthy individuals after a transplant. The demand-supply gap is unlikely to be met, though let's not have an illusion that this is going to be met. So let's do things in a justiciable, regulated manner, whatever little we are doing. Growth in transplantation actually reflects growth of the health system. It reflects trust. I've already said that donation has strong social determinants, and the global experience is that high trust and reciprocity is what pushes donation and transplantation. Why does it need our collective attention? I think in India, we must understand, this is for all my young friends, that actually as a medical professional, you are a thought leader. You're automatically a thought leader. You can punch well above your weight. You can impact on people around you. People look up to you for advice and opinions. A more selfish reason, some of our family members will need organs in the future. The NCD epidemic is very much here to stay. But also, if we all believe that collectively we are developing as a country and as a society, the health system and transplantation is a sign of good development, inclusive development. And also, I talked about the ripple effect. So, I mean, look, these are some of our patients, kids. One of them here I want to point out to, and this is with his permission that I share this, Ojas Sunamne. We transplanted around 15 years back for a very severe liver disease. He finished his MBBS from GS Medical College, is now done his post-graduation in medicine and just training to become a medical oncologist. So we'll have medical students now. We have doctors. They go back to a normal life. I just end with this book. This is Amartya Sen Chandres. So I think if one has to look back at transplantation, yes, I think it's glorious, but there is an uncertain glory. And I think if we bring in these other lenses and attempt to at least try to get them into the discourse and sort of take some corrective steps, it may even become more glorious. I'll stop here and I thank you for your attention.
Thank you so much, sir. We now open the floor for questions. We have. Yes,
Yeah,
ma'am.
we already have 4 questions, so you can ask those.
Yes. The first question is that in case of a live donor, suppose a near relative is a match but is not willing to donate, whatever may be the reason, will face blackish from others who want them to donate. How can one make sure that a live donor is not under any threat of exclusion from relatives?
Right. So there are two questions in that. But anyway, so how can one make sure? So I think, I mean, Ashish can, of course, contribute to this question. But look, if the team, the medical team, uh, is keen to look at coercion even in a family, there are ways to do it. One practice, and we do that, is that if you get a feeling that the donor, the live donor, is under pressure, you can always take them aside uh, and say, look, if you don't want to donate, we will give you a medical reason. In other words, we will give you an alibi not to donate because they are under pressure and they don't want their family to know that they're not willing to donate. So if it comes from the doctor, the family may accept it. So I think it's about being alert to coercion. Uh, it's typically women, I think, but sometimes also next degree relatives. But I think there's a big role for the transplant coordinator here. They must blow the whistle. They must bring this up. So that's what I think the medical team can do. But as I said, we need to be firstly interested in looking at coercion as an issue even in families. How can we tackle? Should I go to the next? Tackle the social and make difficult to increase awareness. Well, I thought a part of my talk was on that, but I mean, this is a big question. This is a very, very wide question. Social and cultural stigma to increase awareness. Stigma around donation? Is there a stigma around donation? Uh, Perhaps not. I'm not so sure whether there's a stigma. I think there is a lack of not even awareness. I think it's a lack of the health system's interest, the way the health system approaches families, and the lack of uh, the family's trust in the system. And I mean, some of you may have been on the other side, right, as family members. So, in a moment of intense grief, somebody's died. Somebody comes to you and says, "Now donate an organ." I'm amazed that people donate organs in many hospitals in India because, in the sense, the health system intrinsically there is a lot of stress, anxiety, but we are not the friendliest of healthcare systems. So, I think it's a reflection of that. I don't think there's a stigma. I think people are intrinsically keen to donate or willing to donate, but I think we lose out because of our the way our health system is structured, and also I think I think our ICUs uh, are very different from ICUs in the rest of the world. They are overloaded, understaffed. So there are so many other reasons. Okay, I'll not go down that route. What is the biggest reason we lose potential donors in India? Failure to identify brain death? Yes. Maintaining donor also. But failure to identify brain death, very much. Um, because, I think the problem is that we seem to have only those who are involved in transplantation currently take interest in declaring brain death. That is the reality. So we need this to go outside of the transplant hospitals, and we have not been able to make that jump. Uh, I think as a transplant community also, maybe we have a problem out there because we are sometimes seen as only interested in the organs. So I think this is a somewhat complex issue. Do you not think that incentivizing will reduce the rate of organ trade? That's interesting. So if you bring it out as a if you bring it out into the open as a regulated market with the state involved, with transparency, with money exchanging hands openly, will it reduce the organ trade? Uh, Not sure. I think it will be hijacked. Uh, it could be hijacked. There could be a lot of under the table dealing still. This is the experience from Iran. But also, what does it mean? Does it mean that we say, okay, so how do we put the price? So a very poor person comes up and says, I want to donate the kidney or a part of the liver. how do we decide the price? Who decides the price? Who pays whom? How do we pay? Is additional payment allowed? Uh, so I think this opens up Pandora's box, and I'm not so sure whether we are ready for this kind of a. But if you're asking me whether therefore we can control the organ trade, uh, theoretically, theoretically yes, but practically we'll open up another Pandora's box. In Indian healthcare and meaning is we're not famous for very good regulation. You must know that, right? Regulation has been a problem. So this will need intense regulation of the highest order. I suspect that it's very difficult. And also the image of transplantation. The moment you bring this in, why should anybody donate for altruism? Why should? If you can buy an organ, why would somebody else donate for altruism? Right? If it's available in some kind of regulated market. So I think these are huge challenges. Maybe Ashish may want to add to this. Please.
Yeah, I think paid is a difficult perspective. I'm one of the believers that who thinks that living donation should be discouraged, actually. I mean, in an ideal world, we should all be taking organs either from the dead or from some other scientific, whatever fiction we see,
Right.
from animals or whatever we can do. But yes, till the time those things are in place, we definitely need somebody to help us out. So there are the living souls. But remember that if we are just basis of transplantation is from the living donors, there are organs which cannot be donated with a living person, right? If you need a heart, you need a lung, so they are impossible to get from living people.
Right. There's another question on maintaining anonymity between the donor and recipient family in a deceased donor. Some anonymous could increase willingness without compromising confidentiality. Okay, that's a fair point, that just giving information without naming the person, right, about the recipient, will it increase the emotional quotient, for lack of a better word? Somebody is dying somewhere, young person. Maybe. I'm not so sure why we completely anonymize this process.
I mean, one
Yes,
of the reasons I can just chip in there. So one of the reasons is that what we have seen is that majority of the donors are from a poor socioeconomic background. And sometimes the family wants to help them out. The recipient families are mostly they are affording, right? So some sort of dependency sometimes, most of the times, like they'll always, for any problem, they'll come and ask for something from the recipient family. So normally we try to discourage that. It's like goes towards an organ trade side type of thing. And plus, then the families may directly start to negotiate. Okay, I will donate only if you give me this much. So we do allow them to interact, but only after the entire thing has happened and the process is over and they're all settled in their lives. At that time, we do allow them. One-to-one, still we try to discourage. So, but like as a group, okay, we invite the families of donors and families of recipients, and then they can and they interact. If somebody is specifically interested, then we just try to see, okay, what is the background and what is the motive. So the motive is only to maintain an emotional quotient, that's fine. Anything more than that, we just try to discourage.
Sure. Okay. Yesterday, one of the speakers talked about the making declaration of brain death a major practice via implementation. So, what the question probably, why is it not mandated to declare brain death, right? Is that the question?
Yes,
Seems
sir.
to be. Yeah, okay, great. Actually, there is no reason to mandate if the brain death is suspected, an intensive care doctor must diagnose it and declare brain death. It's death, right? But there's a problem, right? Now, I don't know whether we should take a dive into that. But the problem is that in India, we still link brainstem death or brain death with the act of donation. whereas it is death, right? So it is independent of donation. Also, we must declare brain death, but not only should we declare, but then we must disconnect the ventilator, right? I won't even say life support because there's no life. So there was historically, I think, a bit of a blunder, right? We put brainstem death in the transplant law. So that's one challenge. So independent of the act of donation, if somebody is brain dead, that means the person is dead. And in an intensive care unit, if somebody has cardiac death, uh, of course they stop everything and hand over the body. So something similar should happen here. And therefore, there's no question of mandating it, it should happen. But it does not. And I think that's partly because of the history. But I also suspect it is because intensive care unit, which is disconnected from the needs and the activity of transplantation, really is not beyond the limit wants to go down that route of declaring somebody brain dead because there is a process involved. And the law, unfortunately, has a somewhat complex process. Not very complex, but you have to get now two set, etc. And they would rather, because they are busy ICUs in India, you know what I said, understaffed, hundreds of people coming in, going out. So I think that's also a problem. So I think it's not about mandating. Anything that's mandated may not work because, by the way, in many states it has been semi-mandated, audits are being done, and people happily say that there are no brain deaths in our intensive care, right? So what do you do? So I think there's a challenge. Now, can we incentivize the ICUs for donation? So Spanish did it. Actually, the Spanish history is that they incentivized ICUs. So, but that's a state system. So they would give funds to the ICU to develop their ICUs. This is about 25, 30 years ago. So that's the kind of incentivization one can look at. You incentivize a ICU if they promote donation.
Thank you, sir. We are like, thank you so much for your insights. Passing on to you, Sunanya ma'am.
Okay, so thank you, Dr. Nagral.
Thank
Once
you.
again, I know you're traveling as well. So thank you very much for coming. And we have our next speaker who has been here for some time. You've already spoken with him. That's Dr. Ashish Sharma. He is a professor and head of the Department of Renal Transplant Surgery at PGIMER Chandigarh. With more than 25 years of experience in transplant surgery, his work has helped expand transplant services in government institutions across several states, improving access to transplantation for patients from undeserved communities. Under his leadership, the renal transplant program at PGIMER has developed into a major transplant center with substantial experience in living and deceased organ kidney transplantation. He also played a key role in establishing the pancreas transplant program and advancement of organ donation, including donation after circulatory arrest and normothermic machine perfusion for donor kidneys. An accomplished academic and author, Dr. Sharma has more than 260 publications and has authored several books. He has also contributed to National Transplant Guidelines and South Asian Guidelines on infectious diseases and transplantation. His contributions have been recognized through several national and international honors, including the Mentor-Mentee Award from the Transplantation Society and the Exemplary Services in Transplantation Award from the government in India and the Fellowship of the Indian Society of Transplantation. Dr. Sharma is also instrumental in holding the PGI Transplant Games in Chandigarh since 2014. And under his leadership, 2025 saw the first fully competitive professional transplant games held in India. Dr. Sharma, welcome. Your topic is Introduction to Solid Organ Transplants.
Thank you, Sunana. Thank you for the kind introduction. I hope I am audible and my screen is visible.
Yes.
Okay, so I've been asked to talk about an overview of solid organ transplantation. So this was the day in, let me just, 1954 when history was written. So this Boston hospital did what people were trying for the last 50 years, that they could actually get one kidney out of a human body and put it into another one, and the organs, they worked, and the patient lived for many years thereafter. So this had been tried for many years, but without success. And the man on the right, Sir Murray, actually did it for the first time. And that is when they realized that it is not the technique, it's not a surgical technique. The culprit so far has been our immune system. So before that, this was not recognized, and people thought that they were trying, somebody was trying an animal kidney, a goat kidney, or a dog kidney in humans, and they were wondering why is it not working. So this led to the development of immunosuppression. Initially, we were very crude. We would just put everyone in the radiotherapy room and give whole body radiation. And then some drugs came, azathioprine, steroids, the lymphocyte globulins. But it was the 1980s when actually the game changed, that we had a molecule called cyclosporin, which I'm sure you people would have heard about it. And that is what led to a dramatic improvement in the organ transplantation. So coming to my topic, so what is solid organ transplantation? It just means that we are putting one organ to another individual, overcoming the immune barriers, right? So it is now expanded not only to solid organs, but also to the solid organs and the tissues as well. And the common organs being the kidney, heart, liver, lung, pancreas, and intestines. But a lot of other tissues are being getting transplanted. So we talked about the indications. So all are mostly that for the organs, if your organs are not working, right? So kidney, you've got an end-stage kidney failure, you're on dialysis. For liver, you've got cirrhosis and you're having challenges with your lifestyle. If your heart has failed, same is for the lung. Pancreas is like you've got diabetes, either type 1 or type 2, and same with the intestine. So if your organs fail, you just get them replaced. That's about it. So this is a pretty older slide, year 2000, but just shows the number of transplants being done in the US in this year. And at least for the kidneys, the numbers close to doubled, and I'm sure about the others would have increased as well. So that's the load what the US is doing, and our population is 3 times the US population. So just imagine if US is doing 25,000 kidney transplants a year, we should be doing close to 75,000 in a year. So other than the kidney, I said that you've got some tissue transplants happening. So this is an example of the various tissues which have been transplanted, including nerves, tendons, knees, and whatnot. And that's one picture I took from the internet. So where a hand and a forearm has been transplanted, and this is an example of a joint transplant. So with the person is able to do all normal function as compared to prosthetic joints. So that's another example of an innovative transplant where the face was bitten by a stray dog, and just see the change in the patient's after the transplant. So the person who was scared to go outside has suddenly become a new entity after the transplant. So other than the face, we're not also doing uterine transplant. In fact, India is one of the leaders in uterine transplant. And that's another one of my favorite slides, where you see that how the transplant impacts your lives, right? So it used to be a life-changing operation, but now it's more of a life-enhancing surgery as well. So this young graduate had an accident while driving a bike, and she ended up with severe injuries resulting in amputation of both her upper limbs. And she was struggling for life when the family decided to donate the organs and the hands of their loved ones, and she underwent an operation. And this is pretty much in our own country, and India is again the leader in this operation. And you see that suddenly the picture in the center is the same girl, and who's suddenly transformed into a brand ambassador for tissue and limb transplantation. And see the smile on her face as compared to the difficulty and the despair which she was having while she had both the limbs not with her. So it's not about the the limbs only. This is an example of a lady, 25-year-old, who developed heart failure, had a second transplant, and she led the Indian contingent at World Transplant Games in 2019. And that's another lady from Delhi who was at the last World Transplant Games in Germany. So, I mean, nobody can tell by this picture or by meeting or interacting with them that they've had some life-threatening problems. There's another lady who's had a type 1 diabetes for many years, and she required multiple admissions because of severe hypoglycemia. I'm sure, I mean, you probably would be knowing that type 1 disease, type 1 and type 2 are very different diseases, whereas type 2 can easily be controlled by giving oral medications for many years. Type 1 requires insulin from the word go. And not only insulin, it's the severe fluctuations. One moment your blood sugar is 500, and you take a shot of insulin, and next you never know that next time your sugar might be only 40 or 50. So she ended up with dialysis. Most of them would end up with dialysis in 10 to 20 years if not taken proper care. And then she had a transplant with us, and not only transplant, she got married and she had a child, one of the very first childbirths happening after pancreas transplant in our country. So that's how it actually changes everyone's lives. This is another example of a patient who's had a kidney transplant with us, and look at his muscular body. I mean, it's impossible to say. I mean, nobody would believe that this man has had a transplant unless you see his scar in his tummy. So is it only that what happens to them after your transplant, right? So what are the survival rates? So this is again an older data, but you see that even in 2007, the 1 year survival are close to high 90s, right? And I mean, they're improving over a period of time. And so it's not only 1 year. I mean, now they're living for many years. And this is an older newspaper cutting, which we used to see that the twins salute 40 years won by transplant. And that was what we used to see read in newspapers. And now this is what is our patient who was transplanted in 1985. I mentioned that cyclosporin came in 1984. And this is one of those eras patients we transplanted and is still alive with us. And just imagine that his father, who donated the kidney to him, is no more. But if you take the life of the kidney, it's now for like more than 102 years. If you think that the donor age at that time and add the number of years later on. So it's not only kidney. We've had reported reports of more than 31 years after heart transplant, 20 years after lung transplant. And so why do we need all these transplants, right? I mean, Dr. Sanjay talked about the burden of disease, and I being a kidney specialist can vouch for it, that India is a very high burden country as far as renal disease is concerned, because of increasing burden of lifestyle diseases, hypertension, our diet, which has become sedentary lifestyles, diabetes, right? And unfortunately, many of them would not be able to afford therapy for either dialysis or for transplant, which are the only two options when you end up with this problem. And out of the two, I think transplant remains the best therapeutic option because you are able to work, whereas in dialysis, you are hooked to a machine at least 3 times a week, 4-hour session, which becomes very challenging for the caregivers. And if you compare the cost versus dialysis for any transplant, the cost is much lower. So if you're spending around close to 40,000-50,000 on hemodialysis per month, your transplant cost would be somewhere around 5,000 to 10,000 per month. So how do we get organs, right? So there are only 2 ways at the moment. Either you have a living donor who can donate, or you get an organ from somebody who's died and the family has agreed to donate the organ of their loved one. So what are the differences in two? I mean, living donor, of course, we can plan it, we can test him. We have a very short times that we know that when the patient is ready, we take the organ out, put it in the ice, and then transplant it right away. For a disease donor, it's not the same. It's an emergency surgery. we don't know, we sometimes have to call the patients in the middle of night. So you tend to keep these organs longer on the ice. And we know that even we have all those newer fluids and all those technologies available to us, but having organs on the ice results in some damage to them. So that is why these organs tend to fare not as good as living donor transplant. So, and how do we select these donors? So there was a question regarding how do we assess that they are not coerced, they are not forced to donate. So I think that's a very important role of a doctor who's assessing the patient. So all the time when the donor comes to you, we always take them into confidence after their initial testing and all. We get them to a separate room and interview them, and we try to see their response, why are they donating, and if they have any anxiety or anything we suspect, then we ask them direct questions that is that you're being you think that is somebody else can donate, or you're being forced or so. And many times they will come up with the real reason once you ensure that okay, this will be confidential between you and him, and we can put off another reasons. So of course, immunity is important. We talked about the initial first transplant, which was between two monozygotic twins. So you need to have a blood group matched. We can go across the blood group at now in the current era with newer techniques, but most patients would be blood group matched, and HLA typing matching will give you a much better outcome in the long term. So, but if you do not have a living donor, then you have to have a donation coming from a deceased person, right? And we know that one donor can save up to 8 lives. And if you start talking about the tissues, even you can actually influence up to 50 individuals from one death. So Dr. Nagaral talked about that India is number 3 in terms of total number of transplants being performed. But if we talk of disease donations, we are at the rock bottom, right at the tail of the entire list. And this is one area which we need to improve. So again, somebody had asked question that why brain death is not being mandated in the ICUs. So I think it's more to do with the practice rather than the law. And the current practice is that if somebody is considered in an end of life situation where the prognosis is dismal, I mean, we tend to send them home. We tend to send them left against medical advice. I think as medical students, you probably may not be knowing, but once you become an intern, you will see that this practice is rampant. Until the time we recognize that this practice has to be stopped, we will not be able to allow people to donate in their end of life situations. So I'll just talk briefly about our own experience, what we have achieved so far. So we're one of the largest academic center of renal transplant, offering MCH degree in renal transplantation. And we've got one of the highest experience of pancreas transplant in the country. In fact, we are the leader. We have a leadership role there. We have helped many centers to grow that program. And we are the only center which is regularly doing donations after circulatory arrest. And we have some real good experience with the normothermic machine perfusion, which is again one of the innovations where we put the retrieved kidneys onto a machine, and we can assess that whether these kidneys are going to work in the patient or not. So with that way, we knowing that okay, these organs can be assessed better and can be utilized safely, rather than trying to test them in extended criteria situations where you know that this donor may harbor some problem. I mean, just imagine that somebody wants to donate but has got some infection. So we can put the kidney on the machine and try to do all this analysis, give some antibiotics, and get rid of the infection and put a transplant. So that's just an example. So this is what we can do with all these technologies. So this is where we started. I joined the department in 2005, and there was no disease donor transplants happening at that time. So we did a major efforts in our donor identification, counseling protocols, and we actually could take up that to about 80 transplants happening from deceased donors in a year. So these are the different things which we have done over a period of years and developed a multi-organ transplants, and we could do this. So this is one of the things which we have pioneered in Asia. And I don't know whether you'll be able to see the video, but I'll just run that. This is a kidney which has been put on the machine, and if you can see that there are drops of urine coming from that tubing which is in the ureter, and this is the machine which is actually measuring the blood flow going into the kidney and what is happening. So all this is very new and at the latest cutting edge of technology across the globe, and we are proud to say that we are representing India at that stage. And this is another example on the left where you can see again that's a different kidney again, which is on the machine and making urine. So that way, even in extended criteria situations, we can actually decide to go for it. So that's the pancreas data. The dark brown color is the national, the yellow are the PGI ones. So if you can see that a single center is almost contributing half of the pancreas transplant to the entire country. Again, that's we are privileged to do all that. So coming to the bottom line, why should it matter to a medical student to know about transplant, right? So Dr. Sanjay talked about that you may need a transplant and all, but I would say that the growth in medical specialty is quite static, right? So there are some disciplines which are growing exponentially, where the current new generation of medical students and doctors would be absorbed, and transplant is one of them, right? And this is a unique field which combines medical and surgery into one discipline, along with your infections, your immunology, ethics, and humanity. So it's a very different blend of specialties together. So apart from being a life-saving and life-transforming procedure, it requires a multidisciplinary team approach, where you need to connect surgeons, physicians, intensivists, anesthetists, pathologists, nurses, pharmacists, coordinators, so many people. So, and most important, it drives innovation. Dr. Sanjay again talked about it, that this is where it tests your hospital's ability to do different things and leads to a lot of advances, not only in the field of transplant, but also in the associated field. That brings to the end of my talk, and have I don't know how many of you can, if you are not, the Gen Z would be able to recognize these. So anything in the text box, if you want to guess what is this trying to represent. Okay, I'll just give you a hint also. So this is what has happened now in transplant, right? So pig organs have been tested and successfully transplanted for at least close to 1 year now, and these organs work in humans. So if this come true, then many of us would be having pig reforms, right? With that, I'll just end my talk and would invite any questions. Thank you very much.
Thank you so much, sir. The floor is now open for questions. Do we have any questions? There is one question, sir. What is the quality of life of living donors?
So essentially, excellent, if you want to be in a brief. So what earlier what you used to say is that living donors tend to live more than other people in the community, right? So why is it so? So basically, when you at least 20 years back, when we are evaluating somebody for being a living donor, we will select the best and the healthiest person, right, without any comorbidities. So naturally, when you are having this selection process, they'll tend to live longer. So US has the data of insurance, and where they've shown that more than 20 and 30 and 40 years now, the living donors do not have any after effects. But that data has changed now, like with a lot of demand, especially in our country, where there is no disease donation happening. A lot of parents actually come forward for donation. And we're now trying to ignore the older paradigm where we are accepting donors with hypertension and diabetes. And that actually scares me that maybe 20 years down the line, we're going to see some living donors coming up with this end-stage organ problems.
We have another question, sir. Any ways to preserve organs has been established so far to be transplanted later?
So far, ice is our best friend, that you keep them cool. at 4 degrees. So that is like gives you a life of about 24 to 30 hours for the kidneys. But yes, we have newer technologies. Just I showed that your machine perfusion where you can put these the organs hooked up to a machine where you can circulate blood. So with that, I think the time has now increased to up to 7 days for kidneys and livers. And there was a report last week only where they said that they've just done a fast freezing to less than 4 degrees, and then they probably, if that techniques they have shown successfully in animals, so if that succeeds, then you will have organs on the shelf if they are available in abundance. But at the moment, I think we do not have organs to keep in the shelf. I mean, we already have a waiting list. So
Thank you, sir. We have another question. You mentioned individualized immunosuppression as a key pillar. What are the main factors you consider when choosing immunosuppression for a transplant patient?
So I think majority of the times it's your HLA matching. If your HLA matching is good, then you probably can be down to lesser immunosuppression. Your organs matter a lot. Kidney, pancreas heart requires a lot of immunosuppression. Same is not true for the liver. Liver is the least immunogenic, so you can actually be needing only one immunosuppressant drug. For kidney, you normally require 2 to 3. But the major factor only is like your matching, HLA matching, and maybe the age. The young people are more reactive to any foreign stimulus, whereas the elderly tend to accept these.
Anyone have any other questions? You can unmute yourself and ask. Okay, I think, no, there's one more. Should we go for solid organ transplantation for minor conditions like early DM that makes the life of the patient convenient? It might exhaust organs for more serious conditions. So is there a guideline to prevent that?
Yeah, I mean, as as a transplanter, you have your own morals and ethics clearly laid out. So definitely, we will not do a transplant somebody for a minor condition, right? So so it's, I mean, it's never, it's early. We never transplant a patient with early diabetes, right? So it's only about 10 years or so when the diabetes actually run through the patient's all organs. And actually, the patients come and ask the other way around: why did you allow diabetes to win all my organs before you decided to do a transplant, right? So most of our patients, when we do a simultaneous kidney pancreas transplant, they've lost their kidneys to diabetes. They've got retinopathy where they're not able to see. They've got a neuropathy. They're not able to get up from the bed. They have got autonomic dysfunction. They have bladder problems. And they actually come and fight with us. Why did you not do the transplant 10 years earlier? Why? But yes, we do not have enough organs. So that's a dilemma. That's again an ethical dilemma where we live.
Thank you, sir. I guess we have.
Thank you so much.
Thank you so much, sir.
Thank you very much.
Let's move on, Aprajita.
Yeah, thank you, Dr. Sharma. We have our next speaker now is Trilly Rachel Matthew, who has 18 years of experience in the field of human organ transplantation. She's currently serving as the Director of Operations, India and Middle East with the Alliance for Paired Kidney Donation. Over the course of her career, she has worked with leading healthcare institutions, including Apollo Hospitals, Medanta, the Medicity, Fortis Memorial Research Institute, and Manipal Hospitals. Trilly has extensive training in transplant procurement and coordination, including a diploma in transplant procurement management from Barcelona, and has also been a speaker and faculty at several national and international webinars and conferences. Trilly is also on our advisory board member of Organ India and has contributed to publications and training resources on organ donation, transplantation, and the role of transplant coordinators. Please join me in welcoming her. She will be leading the topic, Coordination for Living and Deceased Organ Donation and Transplant. Over to you, Trilly.
Thank you, Aparajita. Thank you, MSI and Organ India for providing this opportunity. I'll share my screen once. I hope you can see my screen, right?
Yes, ma'am.
Thank you. So I'll be talking on the coordination part, basically living and disease donor organ transplantation. So you've got a fair idea from Dr. Ashish that how many donors are there, what are the types of donors and all those things. So as a transplant coordinator, I would be focusing more on the role and the duties and responsibilities of a transplant coordinator, both in living and disease donor transplant program. So organ donation involves a transplantation of a human organ or a tissue from a living donor or from a deceased donor, that is after the death, to be used in another. So where the person who donates is known as a donor and the person who receives is known as recipient. So there are types, as Dr. Ashish has mentioned, that there are two types of donors. One is a living donor and the other one is a deceased donor. The limitation with the living donor is that living donor can only help one person. And as per the Human Organ Transplantation Act, the living donor should be 18 years and above. They should be either immediate relatives. So the definition as per the law is the grandparents, spouse, siblings, children or grandchildren above 18 years of age. And other than that, whoever donates, whether it's an in-laws or a friend or a cousin or uncle, whoever they are known as other than near related. So whether it is they need an approval from the committee, whether it is an immediate donor or an immediate relative or other than near related, we need approval from the appropriate authorization committee or from the competent authority. Whereas with the living donor transplant, we don't have an extensive legal, the legal permission is not required. We only require the brain death team to certify, which is much easier than the living donor legal process. And the advantage is that one donor can help multiple recipients, and one donor can save up to 8 lives, as Dr. Ashish has mentioned. So, and the most important part is that there is no age criteria for living donor transplant. And even in the disease donor transplant, you can either donate after brain death or you can donate after cardiac death. Brain death is very common in India. DCD, it's an emerging field, but PGI has successfully started doing that DCD program. In Delhi, recently they have attempted one in Manipal Hospital, the DCD, and that they're doing so well now. Organ donation allocation is done by the allocation center. So every state has got their own SOTO. All SOTOs comes under ROTO. ROTO comes under NOTO. In Delhi, NCR, the allocation is done by NOTO. Rest of the places it is done by the SOTO. And as per the law, the transplant coordinator, who can be a transplant coordinator? The transplant coordinator can be any healthcare professional, whether it can be a doctor or a nurse, allied health science graduate, or a social worker who can coordinate activities related to organ transplant or donation. And what is the responsibility of this person is coordinating all matters relating to removal or transplantation of human organs or tissues or both, for assisting the authority for removal of human organs. So as a transplant coordinator, you have multiple roles. You have to act as a counselor, transplant coordinator, team coordinator, documentation specialist, educator, committee secretary, transplant facility manager, and the most importantly, data manager after all. And as a living donor transplant coordinator, we have certain duties and responsibilities. So first, one of our major duties is that information collector. Information collector, we need to understand the medical history of the patient. As a transplant coordinator, they have nothing to do with the treatment part or prescribe any medicine or decide any treatment, but you need to understand the medical history of the patient because you are the center point of contact for everyone. So they would ask you, so you need to be, you need to know that what is your patient's medical history, and also it will help you to understand the understanding between the donor and the recipient, that I'll come to you later on, and know the donor and the recipient. So in living donor, you have to be very, very careful about the relationship between the donor and the recipient, whatever the claim relationship they are saying, whether we need to prove that relationship. So understand the donor and the recipient, conduct individual donor recipient interview, so that and the coordinator will understand that whether the recipient and the donor knows each other very well or not. And also understand what is the reason for this donor to donate, and what made the donor to decide that he or she is going to donate to such and such person. Especially you may feel that if they're siblings, okay, they will be donating, but it is not like that. They may feel that husband and wife, because they are husband and wife, they are donating because of the emotional attachment. So many times when we talk to them, we'll come to know that the wife might donate because of the pressure from the other family members. So in that case, the transplant coordinator has got a bigger role to play. Counselor. So many a times that the patient come to know that they have got end-stage organ failure, they may not ask many questions in front of the doctor. So as a counselor, a transplant coordinator, you need to understand what are the diseases, and you need to be able to explain to them in a lighter language and in a layman language, so that and it should not be contradictory to the what doctor says. Otherwise, it would be a problem. So you need to make them understand, make them comfortable, and prepare them for a transplant, so that they should know that what quality of life they would be getting after transplant. And you should be also helping them to get the workup on time, completed on time, because so many of the times the patients get lost in the hospital without knowing where to go. And for the transplant, you need to get many clearances, many tests to be done. So the patient, it happens that in the bigger hospital, the patient get lost. So you need to allocate a person who can help this patient and the donor out, or else you yourself have to do it. And the post-transplant counseling is very, very important. Majority of the patient doesn't understand that what is the importance of a post-transplant care for that new organ, and how important is that organ, especially with the young recipients. We need to give a stress on that counseling. And also, definitely, if the patient is undergoing preemptive transplant, they do not know the pain what the others are undergoing on dialysis. So such patients has to be very, very carefully counseled about the post-transplant care. As an investigator, what is the role of an investigator? Because we will come to know about that the claim relationship is husband and wife. And we also need to prove that they are husband and wife through the documentation part as part of the law. So we have to collect all the relevant documents. And the transplant coordinator needs to make sure that only the relevant documents have to be collected. Don't harass the patient. That is also required. But then at the same time, you should be able to prove the relationship also. So collect the docs. That's the reason when you know the recipient and the donor, you will come to know the relationship. Based on that, you will make a checklist and give it to them. Those documents, when it come, you need to verify that document and see that whether that relationship is proving or not, and the documents are genuine or it's a fraud. Those are the fraud or fake documents. And majorly observer, you need to observe the behavior of the donor and the recipient, how they behave in front of you and how they behave when you are not there around. So that you need to understand, because many of the times fake donors can be or illegal donors can be identified in such a manner, and assess their emotional attachment towards each other. So sometimes you may say that in front of you, they may behave like a very good husband and wife or a brother sister, but when they are out of your room, they may walk in two different directions. They may not go and get along with each other. So all these things you need to understand, and also you need to observe their concernedness with each other. So all these things matter a lot. The most important part is documentation. So the TOA has given a lot, 21 forms where we have to fill in for as per the relationship, and these documentations are very, very important. So as per the relationship, the documents have to be filled, documented, meticulously documented, and submitted to the appropriate authorization committee for the approval. And after all this, you are meant to be a decision maker. So you have to, based on the documentation and behavior and everything, you need to decide that, yes, this is a genuine relationship, whether you can go ahead with the transplant or not. If they feel that everything is genuine and all the documents are in place, then you can conclude your findings that whether you can go ahead with the transplant or you have to abandon the transplant process there. So this is all about the living donor transplant coordination. Now coming to the disease donation, it is totally different. So disease donation and living donation coordination is more into, we have a more burden of doing legal part, because legally we need to prove the relationship. Whereas in disease donor donation, the duties are totally different from that. So you have first of all, the most important part is that as a transplant coordinator, you need to identify the donor. How do we identify the donor? You need to have a visit every day to the emergency or the trauma department or the ICU. Meticulously, one transplant coordinator has to do that. And there are classification of donors. So the possible donor is every donor who has got devastating brain injury is a possible donor. Potential donor means a clinically suspected donor of brain death and is the potential donor. Eligible donor is the patient who is brain dead and medically fit to donate are called eligible donors. Actual donor is the person who has actually donated at least one organ or tissue. Utilized donor means at least one organ or tissue of that donor is utilized. So you need to look for every day morning, or the afternoon, the transplant coordinator will have to make a visit and make sure that all the possible, how many possible donors are there, make a register of that. And out of that, how many potential donors or eligible donors are there. So once the brain death is certified, the transplant coordinator's role starts there, or the grief counselor's role starts there. Till then, the transplant it is better to attend all the counselings which has been done, or the briefing which has been done by the doctor. You should be present there so that you also understand that what is doctor speaking to the patient, so that you can also speak the same language in a layman's language rather than the medical jargons. And you are not speaking anything contradictory to whatever the doctor says. Otherwise, the whole show will get rid of that. Because transplant coordinator plays a major role before everything. If they do their role really well, only then the nephrologist or the physicians or the surgeon's role starts there. So it is important that you play your role as a transplant coordinator, they play their role really very wise. So this is the time between the first apnea test and second apnea test, you can prepare the family members for the organ, to accept the fact or accept the reality what is going on. Once it is second apnea test is done and declared positive, then you can talk about organ donation part. So you need to understand when to say, and it is not that there are stages of grief counseling. So only when the patient's family is in the acceptance stage or the depression stage, you need to approach for the organ donation. Otherwise, you will again lose that opportunity. Documentation, again, it's very, very important to get documented. So we need to have brainstem death certificate that is filled by the doctor, the brain death certification team. So in the both the apnea test results will be documented there in the gap of 6 hours. And Form 8 is considered as the consent form. Again, consent form has to be signed before we go proceed with any of the organ donation procedure. And in case of MLC, we need to take NOC from the police and the forensic department. Only if we don't get the NOC, we cannot proceed with that organ donation part. Otherwise, till then, we have to wait for that. And once in case of there is an eligible donor and the consent is done, brain death declared, consenting is done, then we need to activate the entire process. Like transplant coordinator will have to give a heads up to the transplant team, molecular lab, or medical legal team, and most importantly, counseling. Very, very transparent counseling to the family is required. Documentation is very much required, and follow up with all of these people is very much important there. Then as a transplant coordinator, the transplant coordinator need to understand what is the cause of the death, age of the patient, because the retrieval team would be asking for all these questions. So you need to have everything in handy, the personal information of the patient, like a previous medical history or social history, previous disease, and history of any infection the transplant coordinator should be aware of. And the physical exam, like height, weight, BMI, or any a previous surgical scars. What is the chest and waist circumference in case of any heart and lung donation? So all these things are very important. And the complementary tests, like all the blood tests should be there, ancillary test results should be there as per the which all if they are going to donate the lung, then bronchoscopy, they would be asking for bronchoscopy. Sometimes the heart people would be asking for a CAG. So all those things are required, or else we have to arrange for that. And then virology and serology status should be readily available. Documentation, again, it's very important in case of disease donor transplantation. You need to, before shifting the patient to the OT, you need to understand that the verification of the brain death certificate is done, consent is signed, donor's medical record is completed, and you need to understand from the anesthetist and ICU nurse that what is a vascular access going on, what are the inotropes going on, parameters of this thing, because the retrieval team would be asking for that. And you need to get in touch with the transplant surgeon about the ABO and serology results and the brain death node certificate, signed consent, individual organ assessment reports, cross-match results. In case of emergency, then you need to provide the clearances. Otherwise, the surgeon won't be able to start the retrieval. The moment you come to know that there is everything is ready, you need to inform the OT nurse so that she can keep the OT ready for the retrieval process as per the organ. The number of organs are going to be retrieved, and you need to look for they have to check that whether enough ice is available, or sterile slush is available, blankets are available, enough perfusion solution is there or not, and instruments and consumables for organ procurement is there or not. So all these things you need to understand. Otherwise, you need to inform to the retrieval team that whatever they have to bring from their center. And at the same time, as per the allocation center's request, you need to coordinate with the recipient center. And the time of retrieval is based on the time of the heart retrieval. And at the same time, you need to be realistic also. You need to get in touch with the patient family, and according to their convenience and the stability of the patient, you need to fix a retrieval time so that everyone is available in the hospital, donor hospital, during the retrieval time. And while you're transferring the donor to the OT, it is like any surgical patient or any sick patient has been transported to the OT, the same manner. The donor has to be transported, again accompanied by an anesthetist and ICU nurse, and the donor will be transported in a fully monitored, ventilated, and all ongoing infusions will be on there. And this is the most important thing, see, because there will be patients, there will be a team, heart transplant team, heart and lung team, pancreas team, kidney team, liver team. So multiple doctors and then multiple teams would be there, but everyone would be in a hurry to run with their own organ. So make sure that the donor is given the most respect, and the sutures has to be done very properly. All the tubes, all the dressing has to be removed, and the body has to be draped and tagged properly and transported, and the body has to be transported to the mortuary. This has to be, we have to give all the due respect to the donor and the donor family, because everyone will be in there. As a transplant coordinator, he or she will have to take a responsibility in making sure that the donor's body is handed over with all due respect. Packing is also, you also need to understand that there are enough number of packing bags are there or not. So each organ is packed in a triple bag technique. And so that for packing, we require ice slush and perfusion solution. So all these things have to be there. So each organ has got its own preservation time. So we also make sure that all the organ reaches in the destination within the respective time. So the transportation part is that you can either do a green, so we have to arrange for a green corridor or or you have to airlift the organ, or you have to drone is not there in India now. But now it's very common that green corridor and airlifting or a metro carrying the organ in the metro, it's very common in India now. Handing over the body, when you're handing over the body after the donation, it's very, very important. Make sure that the death summary or the death certificate is ready on time. And you have to make all the arrangements for the post-mortem in case of MLC cases. And no objection certificates from the police or the forensic department. It has to be there while you're sending the body for the post-mortem. Organ retrieval report, whatever, in case of MLC, you need to make sure that there is at least one surgeon writes an organ retrieval report that which all organ has been retrieved and taken, so that it becomes easy for the forensic department to do their job. And transportation arrangement to take the body back to their desired place, wherever it is, their house or a funeral place or whatever it is. Make sure that you thank the family for donating their loved one's organ. Most importantly, this is very important, that whatever you do, you need to you have to manage the data, because down the line, this everything will go in a days or 2 days time, but down the line, only data speaks your work. So whatever you do, post-transplant follow-up of the donor and the patient has to be maintained. You need to maintain your management information system and share the data with the appropriate authority and not to in periodical bias, because only your data speaks your work. So as a transplant coordinator, what is the difference between a deceased donor transplant coordinator and a living donor transplant coordinator is that in deceased donor, you need to motivate the family members to donate organs. Whereas in living donor, you need to assess the motivation, because we all get to hear a lot of news in the newspaper that the donors donate maybe because of the commercial aspect. So as per the law, the commercial organ donation is not allowed. So we need to assess the motivation in all living donor transplant program. And even if we don't motivate for the disease donor transplant program, that program will also die. So that's very important for a transplant coordinator to act wisely. Yeah, thank you.
Thank you so much, ma'am. The floor is now open for questions. Do we have any questions? You can unmute yourself or drop the message in the chat box. Okay, I guess we have
Yeah.
no questions.
No questions. Yeah.
We have one question. Who gets the final say in terms of consent for deceased organ donation? Is it unanimous, or in one or two people's consent is enough?
See, that is actually a question that if in case of husband or a wife, they take spousal consent as important one. And in case of a pediatric patient, then parents' consent is taken. But law is not clear on whose consent has to be taken. So we go by the ethical manner that if the patient is married, then spousal consent should be there. But then we take two witnesses. Whoever gives the consent, we'll have to have the ID proof of that person. But in India, for saying yes, we need the immediate relative. No can be said by anybody. Even a padosi can say no. So that is one no is considered as no. But for yes, we look for the apt one. That is a lacuna here. Yeah.
Thank you so much, ma'am. Moving forward, we now have a group activity,
Yeah,
role play
thank you.
videos. Thank you, ma'am.
Thank you, Trilly.
So we now have the role play videos on breaking bad news, and grief counseling, video evaluation, feedback, and discussions. I would now like to invite Jasmeet ma'am and Dr. Sulav sir. They have been seen what you have submitted, and now it's over to them.
Good evening.
Good evening, ma'am.
So, will you play the video?
Do you want to play them? So we can stop and explain.
I think it would be wise if you can play them from your end, and I'll tell you where to pause in case I want to
Okay.
change the narrative there.
All right.
And I might switch off my video intermittently depending upon my Wi-Fi connection.
So Pujita, are you playing them?
Okay, ma'am, you want me to share the screen?
Yes.
Okay, ma'am, give me a minute. Is the screen visible, ma'am?
Yes.
Let me know if you are able to listen to the audio.
The following role play will be played.
Is the audio audible?
Yeah, we can hear you. Yes.
Okay, this is the first scenario, ma'am, presented by the group 1.
Yes.
The following role play will be played by Gayatri as Mr. Gupta's wife, Athar as his father, and the treating doctor by Gomti. One fine Sunday evening in a happy home. Meenal, did he say when he will be home?
Yeah, he said he'll be home shortly. Let me call him once.
Okay. Hey, I am on my way. I will be home shortly.
Okay. Drive carefully. We are waiting for you.
Yeah, I will see you soon.
Yeah. Bye.
Good. I will get dinner ready.
Yeah, let's have dinner.
Sure.
Sure.
After a while, father receives a phone call. Hello?
Hello, is this Mr. Gupta's family? I am calling from KSG Hospital. Your son has been brought to our emergency department following a serious road traffic accident. He has sustained severe injuries and is currently in a critical condition. We need you to come to the hospital immediately.
What? Is he conscious?
He is receiving emergency treatment right now. Please come to the hospital as soon as possible.
Yes, we are coming.
Papa, what happened?
There has been an accident.
Mr. Gupta's father, Minal?
Yes.
Yes.
I am Dr. Gomati. I am one of the doctors treating your son. He was brought to us following a serious road traffic accident. He has sustained a very severe head injury along with abdominal injuries. His initial assessment showed signs of severe brain injury, and a CT scan showed extensive swelling of the brain with herniation.
Doctor, please save my son.
Please, doctor, do whatever you can.
We are doing everything medically appropriate for him. He needs emergency surgery to relieve the pressure on his brain.
Will he survive?
His condition is extremely serious, and I don't want to give you false reassurance. But right now, our priority is to stabilize him and treat his injuries.
Can I
Please, doctor,
can I
please just
pause?
save
Can you
him.
pause this here?
Yes, ma'am.
Yeah. So this so the question being asked is, will he survive the surgery? Right, by the
Yes.
relatives.
Yes.
Now, when such a question is being asked, in this scenario, there should be a multidisciplinary team. There should be the neurosurgeon. There should be either the ER. I'm assuming that she's the ER doctor, right? So she's currently playing multiple roles, but it has to be a multidisciplinary team to answer this question. Will he survive the surgery? Right? One doctor should not take up the responsibility of answering all the questions which come up in the management of such a complex patient with unexpected outcomes after the surgery. So instead of saying that I can't give you false reassurance, all that has to be said is that this surgery is extremely essential. We have to act fast, and we'll have to see how he fares after surgery, right? We can't start saying that false reassurances can be given at this stage or not. And plus, you need a neurosurgical team at this point. Okay?
Okay, ma'am.
Yeah, you can play it.
Yeah.
The surgery has been completed, and your son is now in the ICU. His brain injury remains extremely severe. He is unconscious and requires ventilator support.
Is there a chance he'll wake up, doctor?
At this stage, it's difficult to predict. We are continuing treatment and monitoring him very closely.
But his heart is still beating, right?
Yes, his heart is beating, and we are continuing all appropriate supportive treatment from our side.
Then please don't give up on him.
We aren't. We'll continue to monitor him and keep you informed.
Yes, doctor, we'll wait.
Mr. Gupta, Minal, I would like to talk to you about something important changes in your son's condition.
What happened? Has he gotten any worse?
Is he all right, doctor?
I'm afraid I have some very difficult news to share. Despite the surgery and all the treatment we have provided, his brain injury has progressed severely. Today, he has no brainstem reflexes and is not making spontaneous breathing efforts. These findings are highly concerning for possible brainstem death.
Brainstem death? What does that even mean?
Pujita, can you stop here?
The brainstem controls essential.
Yes, ma'am.
So are these role players online right now? Is Dr. Gayatri online so that she can respond in case I change the narrative here?
Yes, ma'am.
Right.
Yes.
So Dr. Gayatri, the moment you mentioned that he is not making progress in the right direction and he's actually deteriorated, right? And you start saying that the patient is brain dead, the wife panics and
Ma'am,
says,
just a
no,
second.
doctor.
Sorry to interrupt you. I have played the wife.
Oh, sorry. So the doctor is
Gomti ma'am.
Gomati, yeah. Is she online? So sorry.
Yeah.
Is Gomati online? It's all right. Anyone can answer since it's for everyone. If the wife panics and says, sorry, doctor, I don't want to hear anything negative. I'm quite sure in my gut that my husband is going to recover and he's going to come back to me. Please do not mention any such word as death, I'm not in a position to understand this, what will be your reaction at this stage? Anyone wants to volunteer? She gets absolutely emotional and says, sorry, I will not accept that he's deteriorating. I'm very sure that he's going to improve and he's going to come back to me. And that this happens. They hold on to hope. How will you deal with this reaction of the wife?
I think so. Since you had asked me, I'm putting my view that what the doctor can do that for the meantime we can hold the discussion firstly. Then so the person when he is brain dead, he's basically on ventilator, right? So as the days would pass, the body won't be responding, and I think the wife herself will be like they should be allowed to enter the ICU and just see the condition that just if we remove the ventilator, the person will die. So explaining that situation, it will take some time, and yeah, I think slowly she would be able to understand then. In the meantime, after seeing the condition,
Very well
and
done, Gayatri. Very well done.
also the doctor can share some previous case where such thing has happened and people have cooperated, or some scenario that the lady would be able to relate.
Okay, so first of all, very well done that you halt the discussion there, right? You don't want to force information on this spouse who's not in a mental frame to accept the bad news that you're about to deliver, right? So take a step back. Be in her shoes. She is still in the anger and the denial phase. So obviously no point forcing information on her. At this point, what one would tell the wife is that we can understand the situation she is in. And yes, we are continuing the critical care. We are doing the best possible for the patient, for her husband, and we will continue to monitor the situation. We will update you as soon as we have any further update. But please be available for any further counseling when we need you for counseling, right? So soften the blow a little bit, right? She's not in a situation to accept. Then, as you correctly said, you will allow them access to the patient, and slowly she will herself realize. Sometimes everyone's curve is different. Sometimes patients' relatives take a day or two, and sometimes they might come back after a discussion within the family, and the wife has been explained by multiple family members, and they might come back in a few hours also saying that, okay, fine, we are ready to hold a discussion which we had postponed in the morning. So you assure them that you're available for a discussion when she is in a better frame of mind. You offer her comfort and tell her to take her own time, and give her the liberty to come back to you whenever she's ready for further discussion on this matter, right? You can go ahead and play the video, Pujita.
Yes, ma'am.
Functions such as consciousness, breathing, and important reflexes. When brainstem function is completely and irreversibly lost, the patient has died. However, these findings are currently suggestive of brainstem death. The required medical assessment and testing must be completed before brainstem death can be formally confirmed.
But his heart is still beating, right? How can he be dead if his heart is beating?
I understand why that is confusing. The ventilator is providing breathing support and supplying oxygen to his body. This can allow his heart to continue beating, but the ventilator cannot restore brainstem function.
Can't you do any another surgery? Please, doctor, we have waited all these days.
I know, and you have done exactly what we asked you to do. You have waited while we continued treatment and monitored him. But if brainstem death is formally confirmed, further surgery cannot restore brainstem function.
So there's really no hope.
If brainstem death is formally confirmed, there is no possibility of recovery. I'm very sorry.
Pujita, can you pause?
Yes, ma'am.
So Meenal then asks the question, Doctor, how are you going to confirm this brain death? anyone can volunteer to answer this question. How are you going to confirm? How long will it take?
We learned that yesterday that we need 4 physicians to declare someone brain dead. We have to do it 6 hours apart, and there are multiple tests that they perform,
Right.
and every physician has to individually sign off.
Exactly. So it is important to inform the process to the relatives so that they know that it is not a single individual's decision. There are multiple specialists involved in testing at 2 different points of time to confirm the findings of the first test. And it is not just one person deciding that, okay, the patient is brain dead, right? So give a brief idea about the process and also explain about the apnea test. Right? That basically what you will be testing is the patient's inability to take a breath, right? Which is the definition of death. Once there is no ability to take a breath, the patient is dead. So give an idea that the test is called as apnea test. It will be done twice by 2 separate sets of specialists, and only then will it be confirmed that the patient is actually dead. Right. Go ahead, Pujita.
I was expecting him home for dinner. I spoke to him, and I can't believe this is happening now.
I know, Vinal, you went from expecting him home that evening to being here today. It's completely understandable that this feels impossible to accept.
But he is my son. I don't know what we are supposed to do now.
You don't have to decide everything right now. Let's take this one step at a time. What is worrying you the most right now?
I am afraid we will make the wrong decision.
That's completely understandable. First, I want to make sure you understand what has happened, and then you will understand all your questions. Could you tell me in your own words what you understood about his conditions?
So his brain has been severely damaged. He has no brain reflection and he isn't breathing. But still, it has to be formally confirmed, right?
If the formal assessment confirms brainstem death and if your son is medically suitable, organ donation may be possible.
Doctor, are you asking us to donate his organs?
I understand why that might feel sudden, but I want to make something very clear. This treatment and any discussion about organ donation are completely separate. Our priority throughout his treatment has been to save his life. Nothing about organ donation has influenced the medical care he has received.
But how can we even think about organ donation right now? We are still trying to understand what is happening with us.
And you don't have to make a decision immediately. My role is to give you the information you need and answer your questions. You should have time to process what has happened and discuss it as a family.
If we agree to donation, will his body be disfigured?
I understand why that would concern you. Organ donation is carried out respectfully and according to established medical and legal procedures. Your son will be treated with dignity and respect throughout.
And what about the funeral? Will we be able to have a normal funeral?
The transplant team can explain the practical details and arrangements to you. We will make sure your concerns are addressed. Okay. Something important. Did your son ever talk to you either about organ donation? Did he ever tell you what he would want in a situation like this?
No, we never really discussed it as such.
Neither did we.
That's okay. Many families don't get the opportunity to have that conversation. What we can do now is think about what he might have wanted.
I just want to make sure you are not giving up on him because there's possibility of donation.
I completely understand the concern and I want to reassure you. We are not giving up on him because of organ donation. The decision about organ donation only comes into consideration the brainstem death has been appropriately assessed and confirmed. Until then, his care remains focused on him.
Okay, I just needed to hear that.
Of course, you deserve to have that reassurance.
Can we have some time to talk about it?
Of course, you should have time to talk together and consider what your son would have wanted. You should never feel pressurized into making this decision. Our role is to give you accurate information, answer your questions, and support you.
Thank you, doctor.
I'm very sorry that your family is going through this. We'll remain available to you and support you throughout whatever comes next.
Dad, I just looked on Google about the organ donation on the Noto website. It has all the information, and what I found is the donation is as per a waiting list. They don't randomly just donate organs to rich people.
Yes, बेटा, after all, जीवन दान तो सबसे बड़ा दान होता है.
Yes, Papa, I think we took the right decision. So, doctor, we have decided, we have discussed enough, and we are ready for the organ donation.
Yeah, we would like to go through it.
I understand that both of you have discussed with family members too to donate organs. I appreciate your
Pujita,
decision,
can you pause
but I
here?
wanted to
Yes,
ensure.
ma'am.
Yeah, so in this scenario, I would give an alternative scenario where the father says, yes, I want to donate, but the wife says, no, I don't want to donate the organs. What will be your reaction? Or initially both agree, but later on the wife comes and says, no, sorry, I've reconsidered and I don't want to go ahead with the decision of donation. What would be reaction? Anyone just volunteer and answer the question. The answer lies in the previous talk, actually. Hello?
It won't happen.
Sorry. So yes, absolutely. In the hierarchy of the next of the kin, the spouse has to agree. And if there is a conflict, internal conflict, you have to give them time. But at the end of the conflict, the spouse has to agree, because in the hierarchy, as Trilly told you, the spouse comes first, then the children, then the parents, and then the siblings. So be aware of the hierarchy of the next of the kin. It's extremely important that you don't break that hierarchy medico-legally. Okay, go ahead, Pujita.
Yes, ma'am.
For you guys that both of you understand the risk and implications of organ donation, and your consent must be completely voluntary without any pressure from anyone. We'll guide you throughout the required medical evaluation and legal consent process. Thank you for your courage and willingness to consider donation for your loved one. From your
Thank you, doctor.
Thank you, doctor.
Organ donation is not end of the life, but beginning of many others. One donor can save up to 8 lives and improve many more. In India, thousands wait every day for a second chance. Brain death is real and irreversible, but organ donation is ethical, respectful, and transparent. Today, this family chose hope in the face of grief. Be a donor, give the gift of life.
So that was excellently done by all the
The
three of
following-
them. I must congratulate. Hello? Sorry, so I
Yes, ma'am.
must congratulate all three of you. It was very well done. The doctor was extremely empathetic and was patient, and she was listening to every question and answering every question with patience. The only thing is, couple of observations I would like to tell you is that this should not be a conversation between one doctor and the family. There should be a nurse present. If possible, a nurse should always be present. Maybe one of your juniors also is there. And as Trilly said earlier, involve the transplant coordinator also, because some questions may be beyond the scope of your knowledge, and the transplant coordinator can help you out with help the family with those answers. So always have a team on your side. Introduce all your team. The team also makes the communication witnessed in case you don't have it being done under audiovisual. so that there is no confusion later about what you tried to communicate. So please never do it alone. With the relatives, have your colleagues with you, have a team so that there is witness to the entire conversation. If possible, do it under audio visual. In today's day and age, in my hospital, it is mandatory to do it under audio visual sort of monitoring, and it's recorded and it's kept in record in the hospital database. So that was very well done. I think most of the essence of the counseling was absorbed in that case scenario. Next case. Sunena, you have anything to add?
No, it's looked good. I just thought the talk about the organ donation came too fast before they understood
Yes.
what was happening.
Yes, I
But
think
that's
the
all.
brain death. The brain death needed to be explained in more details. The knowledge part needs to be in more details. Next case scenario.
खाना बना
Yes, ma'am.
लेती होंगी, ये आने ही वाले होंगे.
Have you made the food?
Oh my God.
क्या हुआ? Are you okay? आप ठीक हो? Hello. I think she's collapsing. I have to call the ambulance. Hello, wake up. उठ जाओ, क्या हुआ है?
Doctor, this is the CT scan of the patient. It shows large intracranial bleed with intraventricular extension and uncal herniation. And neurosurgery has assessed that there is no role for surgery. She is intubated and mechanically ventilated for now.
All right, her condition is extremely critical. We are providing supportive treatment and monitoring her very closely.
But she was completely fine when I left home. How did that happen?
I understand how sudden and overwhelming this is for you, but right now she is unconscious and needs the ventilator to support her breathing.
But she'll wake up, right?
So at this stage, we cannot give you false reassurance. We need to continue assessing her situation and will explain every significant change to you.
Doctor, her blood pressure and other parameters are stable and she has good urine output. However, she has no response to painful stimuli and her brainstem reflexes are absent.
All right, thank you. Sir, I'd like to talk to you about what we are seeing.
Is she getting worse? She was stable, right?
Sir, her heart and circulation are being maintained, but we are concerned about her brain function.
The examinations have shown that she is not showing the normal responses that come from the brainstem.
Sorry,
What does that
Pujita,
mean?
can you halt here?
It
Can
means
you halt?
Yes, ma'am.
Yeah, so that's the exact question a relative asked. What is brainstem? So anyone volunteer to answer that question? What is brainstem? Anybody? How will you answer this question?
Brainstem is usually which controls the vital centers like respiration, circulation.
Yeah. Yes, so you have to answer in a language, in a very simple language that they will understand, that usually brainstem is the center in the brain which controls the most vital organs of our body, which is the heart and the respiration and our consciousness, right? So very simple term in their language. So we are conducting this, workshop in English, mind you. Only 1 out of 10 situations you will be able to talk to the relatives in English. It will have to be in the language, in their native language as far as possible, to make it simpler for them to understand, because most of them get confused with this brainstem. Okay, go ahead.
That
can
we are
play, Pujita.
concerned that she may
Yes,
have
ma'am.
suffered an irreversible loss of brainstem function.
No, that can't be right. Look at
Sir,
her, she's breathing. Her
yes,
chest
sir,
is
you
moving.
are. Yeah, you are absolutely right that you can see her chest moving, but that movement is being produced by the ventilator. The machine is pushing air into her lungs.
But what if she's breathing? How can she be dead?
So this is one of the most difficult things for families to understand. The heart can continue beating and the ventilator can continue moving air in and out of the lungs, even when there's an irreversible loss of brainstem function.
Doctor.
Yeah, Nitya,
Okay.
yeah, start.
So this is one of the most difficult things for families to understand. The heart can continue beating and the ventilator can continue moving air in and out of the lungs, even when there's irreversible loss of brainstem function.
So the machine is keeping her body going.
Yes, sir. The ventilator is supporting her breathing and the ICU team is supporting her other vital functions.
And I saw her fingers move. She moved them when I was sitting beside her. That means she know I am here.
Yes, sir. I understand why that movement would give you hope. However, sometimes movements can occur because of spinal reflexes. Such movements do not necessarily mean that the brain or brainstem is functioning.
So she didn't move actually because she heard me.
Not necessarily. I know that is very difficult for you to hear. That is why we rely on formal neurological examinations rather than movement like these to determine whether brainstem function is present.
This is
Pujita, can you
ridiculous. How
stop
can you tell me that?
Okay, now
Yes.
the husband says, why can't we repeat a scan to see if her brain is functioning? I want you to repeat the MRI and see whether her brain is functioning or not. Response. Anybody can respond to this? So basically, this demand comes in more often than one would anticipate. They want you to repeat sets of investigations, like do a EEG or do a CT scan again, and they demand that no, we want you to do a scan before you declare the patient brain death. And the answer to this question is that no scan can tell you what actual functional state of the brain is. It's only bedside clinical examination. And that is why all over the world, by law of all the countries, when the brain loses the ability to initiate breath, it is called as brain death. And that is all we need to do is bedside assess the patient's ability to breathe. If it is not there, it is defined as brain death, and no other investigation is necessary once that test, that is the apnea test, comes positive. So one has to be gently firm in saying that no further investigation will answer this question. Only the clinical examination and the apnea test is necessary to declare a patient brain dead, right? Because this request will come. Okay, go ahead.
Wife is dead when her heart is beating. You're just giving up on her.
I am sorry, sir. I can see how upsetting and frightening this is for you. You have been given a lot of information very suddenly.
Yes, but we are not giving up on her. Our responsibility is to establish the medical situation accurately and explain it honestly.
She was cooking just yesterday. I left for a few hours and now you're telling me she's gone.
Yes, so I know this happened incredibly suddenly, and I'm very sorry that you and your family are going through this. You don't have to process everything at once. We'll explain it step by step. So, once brainstem death is formally confirmed, there's another important matter we may need to discuss with you: organ and tissue donation.
Organ donation, but she's still alive. Her heart is beating.
So, I understand why you feel that way. That is why we would never start this conversation before explaining and formally establishing brainstem death.
If brainstem death is formally certified, organ donation can become possible because the circulation can temporarily be maintained with medical support.
But if you take her organ, won't that cause her death?
No, so this is very important for you to understand. Organ donation does not cause brainstem death. The death has already been established through the prescribed medical and legal process before donation is even considered. The doctors responsible for your wife's treatment and determination of death are separate from the transplant team. The decision about her treatment and certification of death are not influenced by whether or not she becomes a donor.
Firstly, why would you want her organs?
So, because if she is eligible to donate, her organs and tissues could potentially help other patients who are suffering from serious or life-threatening illnesses.
Yes, for example,
Okay,
organs
Pujita,
such as
can we stop here?
kidneys, liver.
Yes, ma'am.
Okay, now the husband says, okay, I've heard you. I've heard your request. I don't want any further conversation on this right now. I want you to please continue treating my wife as a patient and try to save her. What would be your response? Anyone?
Ma'am, we can say that if you don't want to consider the proposal of organ donation, then you can surely not consider that. But for the part of trying to treat your wife, we have already tried and we are trying as well. But now clinically it has been established that she is brain dead. So we cannot make her wake up again, or we cannot make her become alive again. But for the organ donation part, you can be rest assured that we will not force it upon you. You can decide it later.
So that's called as respecting the family's autonomy. They have the autonomy over their loved one, and their wish has to be respected. And you have to reiterate that it is voluntary, and that we are not forcing you to take this decision of donation. It's only an option in front of you. But at the same time, you can also gently motivate by saying that what can happen is that few lives can be saved by one decision on his part. Though it's a difficult decision, it's a very hard decision for him, but at least 8 lives can be saved, and that something good might come out of this disastrous situation. So gently put that in the conversation, but don't force, right? So basically respect the autonomy, and once you put that thought that maybe his one decision can save 5 to 6 or sometimes even 8 lives, that leave that thought there with him. Leave him with that thought. And that when they process that, they come back and say that, okay, fine, I've given it enough thought, and maybe I want to consider it. So then they'll ask you about the details as to how can I go ahead with it. Okay. Go ahead, Pujita.
Yes, ma'am.
Heart, lungs, and pancreas may be considered for transplantation depending on the medical circumstances. Even certain tissues, such as cornea, skin, and bone, may help other patients.
So she could actually help someone else.
Yes, one donor can potentially help multiple recipients. For a family, donation can sometimes provide a sense that something meaningful has come from an otherwise devastating situation.
But I don't know if she ever wanted this.
So that is completely understandable. Do you know whether she had ever expressed her wishes about organ donation? Perhaps in a conversation with you or another family member?
I don't remember us ever discussing it.
That's completely okay. You don't have to have an immediate answer. We can give you information, answer your questions, and give you some time to discuss it with your family.
But tell me, what happens to her body after donation? Will she be disfigured?
No, organ and tissue retrieval is performed surgically and with respect and dignity for the donor. After the procedure, the body is scared, and the family can proceed with the funeral and last rites according to their wishes and customs.
Does the family receive money for donating the organs?
No, sir. Organ donation is a gift, not a commercial transaction. Organs are not something that the family sells. The process is carried through authorized transplant system with allocation based on established medical and legal criteria.
I don't know. I feel like it's actually happening too fast. The decision about my wife, why I have not even accepted that she is gone.
Sir, that's completely understandable. You have just experienced an enormous loss and you don't need to feel pressured at all.
Yes, our first responsibility is to make sure you understand her condition and have had the opportunity to process what has happened. Organ donation is completely your decision. We are here to provide you with information and support, not to force you into saying yes.
If I agree, will you still treat her with the same care and respect?
Yes, sir, absolutely. Every effort to treat your wife and determine her condition is made independently of any decision about organ donation.
And throughout the process, her dignity and your family's wishes will be respected.
I don't know what she actually wanted, but if she could have someone else, maybe that's something I should think about.
Yes, sir. Take your time. We can arrange for the appropriate transplant coordinator to speak with you, answer your questions, and explain the process in detail.
Yes, you don't have to make this decision alone.
Okay, I would like to understand this about more.
Of course, we'll stay with you throughout the process.
It's done now.
Yeah, that is good. Basically, they left the patient with the contact of the transplant coordinator. That is most important. Trust me, the backbone and the pillar of organ donation is the transplant coordinator, and it is wise to include the coordinator in all the conversations with the relatives, because in the presence of the doctors, they may be intimidated, not have the questions ready. And I usually tell them that you may have more questions will come in your mind. Sit down, write all those questions, and come back with those questions in our next meeting, or get to the transplant coordinator and he will be able to answer all those questions. So never miss out the transplant coordinator in this conversation. Yeah. Okay. The last scenario.
One. Hello, everybody. Today, our group is going to do a role play about breaking bad news after an unsuccessful resuscitation. I'm Nitya, and I'm going to play the role of Mrs. Thomas, who is the wife of Mr. Thomas, the deceased.
Hi everyone, my name is Shri and I'm going to play the role of Dr. Arjun.
Hello everyone, this is Naresh Harwa and I am going to do the narration of the story and I am gonna play the role of the son. It is a Sunday morning. Mr. Thomas, 40-year-old male, is attending mass at his local church. During the service, he suddenly complains of chest pain and collapses. The people around him immediately call for emergency medical help and begin CPR. CPR is continued until the ambulance team arrives. The medical team takes over the resuscitation and transports him to the emergency department. Despite continued resuscitation in the hospital, return of spontaneous circulation is not achieved. His wife, who had accompanied him to the hospital, is waiting outside the emergency department along with several people from their church. The following conversation takes place after the medical team has made the decision to stop resuscitation.
Mrs. Thomas,
Yes.
hi, I'm Dr. Arjun. I'm one of the treating physicians who has been looking after your husband.
How is he, doctor? Is he fine?
Can we talk somewhere more privately?
Okay.
Okay.
Pujita, can you pause here?
AMK, private room.
Yes, ma'am.
So this is a very important step, and I'm glad that this team has highlighted this step, because the ER is a very busy room with multiple patients around, and each patient will have 4 or 5 relatives around them. So it's very important to hold this conversation in a more private place rather than by the bedside where everyone else is listening to that conversation. So very well highlighted by this team to respect the privacy of this conversation. Okay, go ahead, Pujita.
Yes, ma'am.
Okay, Mrs. Thomas, please take a seat.
What happened, doctor? Is he all right?
Before we start, can you please tell me what you've been told so far?
He was at the mass and then he suddenly had chest pain and collapsed. People started doing CPR and the ambulance brought him here.
Okay. So I understand. Uh, Unfortunately, I don't bring any good news today. Yes.
Again,
Have you been
Pujita, can you
trying to
pause?
revive him since then?
Yes, ma'am.
So that's another great point here. He has fired the warning shot, what we call as he has braced the wife for oncoming news rather than just blurting it out that, sorry, we tried everything and he's no more. He's warned her that, this is not something that you want to hear, but I have to tell you this. So always remember to prepare the patient mentally by firing this warning shot that what I'm about to tell you is not something that you want to hear, but I have to update you about the facts. Go ahead, play it.
Yes, ma'am.
Yes, ever since your husband collapsed and CPR was started, we have continued to give him CPR since he arrived in the hospital.
So he's going to be okay, right?
Unfortunately, Mrs. Thomas, I don't have any good news for you today. Your husband was in cardiac arrest. Despite giving him CPR and other interventions since the last 40 minutes, your husband was not able to, we were not able to restore Mr. Thomas's health, circulation. Unfortunately, your husband has died.
That can't be right, doctor.
I understand, Mrs. Thomas, that this may be very sudden and disturbing.
You're lying. He was fine this morning.
I can understand that, but unfortunately, Mr. Thomas is dead.
So, Pujita, can you pause
He's
again?
supposed to come
Yes,
home
ma'am.
and
So again, well done by the doctor here. Rather than using terminologies like we could not achieve ROSC or we could not get his cardiac activity back, it is best to say it in simple terms, which he'll understand, is that we gave 40 minutes of full resuscitation, but at the end of it, we could not revive him and your husband is no more. And he used the word that he died. But yes, either of these two, give very clear language. Don't say that the heart could not be, cardiac activity did not come back, and that's all a jargon for them. Give a clear message with simple terminology and don't confuse with jargons. So very well done by Shreya here. Go ahead.
don't understand. You tried everything?
Yes, we tried everything.
The ambulance people too?
Yes, them as well.
Then why didn't it work?
Unfortunately, despite all the attempts, sometimes we may not be able to restore his circulation, and thus your husband has died.
I don't know what to do.
Would you like for me to call someone from your family to be with you right now?
Yes, my son Daniel needs to be here.
Okay. I can be here with you while you call him.
I'd like that, thank you. Daniel, can you come inside? Yes, to the private room.
Hello,
Yes,
Mr.
ma'am.
Daniel.
Hello, doctor.
My name is Dr. Arjun, and I was one of the treating doctors for your father since he arrived at the hospital.
Yeah, how is my father now?
Unfortunately, Mr. Daniel, your father has died. We were
That
not
can't
able
happen.
to.
That can't happen. He was with us in the morning today. How can that happen?
I understand, Mr. Daniel, but your father had a cardiac arrest today
So
morning,
Pujita, can you
and
pause
we
here,
have been
please?
trying to revive him for
Yes,
the
ma'am.
last 40 minutes.
Yeah, so here I think it was a very direct blow without a warning shot to the son. Probably a background should have been given about how it started, how he reached, because he was not there present for the initial conversation. So never be very blunt in the beginning. Always give them a background and then sort of deliver the news. Go ahead.
Unfortunately, we were not able to save him. Your father has died.
Did you guys even try your best?
Yes, we tried our best. We've been giving CPR for the last 40 minutes, and we also gave the other possible treatments.
Can we see his body, doctor? When can me and Daniel see his body?
Yes, we will arrange for you to see your husband.
Okay. We would like some private moment, if you would allow us. Is there anything else you want to talk about?
It's okay. I understand that this is a very difficult and you may need your time to cope with this. So if you have any questions, please feel free to reach out to me or anyone for that matter.
Okay. Doctor leaves and gives some personal space to the mother and the son.
Okay.
After a few brief moments, the doctor again enters the room with a few papers in his hand.
Hello, Mrs. Thomas. Hello, Mr. Daniels. Unfortunately, and this is very time sensitive, and this may be very uncomfortable for you to talk about. We want to talk to you about organ donations. Your
you guys
husband
even-
seems to be. Your
Are you
husband
guys
seems to
even-
be.
Yes, ma'am.
Yeah, so I deliberately put this scenario here of CPR going on in a cardiac arrest. I want as many answers as can be given. Do you think this patient can donate his organs? He's received 40 minutes CPR. Can he donate his
Maybe
organs?
some of the organs we can give, like cornea and other such organs. But mostly they are not viable since circulation had collapsed.
Right. So, this is, you're all medical students, and probably by the time you will be practicing, hopefully in this country, I think Dr. Ravi Mohanka had introduced this concept of donation after circulatory death, right? Currently, it is not practiced very widely in India, but there is more and more awareness about DCD. Please read up. Every website gives information about DCD. Such a patient with an ongoing CPR, if you have given adequate CPR after 40 minutes also can be considered, but there is a process to it and it is beyond the scope of this presentation and probably not being practiced so well in India. Abroad, if you go into UK, 40% of their organ retrieval is after circulatory death, that is after unsuccessful CPR. There's a strict protocol to follow. There is a hands-off process timing, which can be anywhere between 3 to 7 minutes, depending on the country you are in. After that, the patient is declared dead. Again, the CPR is started or the patient is put on ECMO for circulation to maintain the organs, and then the organs are retrieved. This is information I'm giving you. It's probably new to you or some of you know about DCD. Not widely practiced. There are only 2 or 3 cases reported recently. I think somebody in the talk did mention about Manipal doing one DCD recently in Delhi. So in the future, I think DCD will increase in India, and that is why this conversation in this patient is crucial, because he's a young fellow. You have tried your level best to save him. There has been more than an hour of CPR because in the ambulance, in the church, and now you have also given, and you have reached a point where you know that ROS cannot be achieved, but because you have given good quality CPR right from the moment the patient collapsed, bystander CPR was given. the quality of the organs might still be preserved, and it might be possible to convert this into what we call as DCT. Again, I am emphasizing it's not very commonly practiced, but by the time you guys are in the field in another 10 years' time, we are hopeful that there will be more and more acceptance of DCD. Mind you, it's difficult for the relatives to decide in a very short span of time because they have hardly few minutes to decide this. But once there is more awareness, I'm sure there will be acceptance also in the population about DCD. Okay, go ahead. But as of
Let's
now,
wait
yes, they can
until
donate
some-
the cornea and the tissues, not organs as such.
Yes, ma'am.
time else, doctor.
Okay, play it. Yes.
Unfortunately, Mrs. Thomas, this is very time sensitive. The organs only remain viable for a few hours after death. Thus, we need to talk about this right now.
Are you guys even serious? My father has just passed away, and you are hovering over his body like vultures, trying to pick up the organs and do what? Traffic them?
I understand your anger, Mr. Daniels, but the thing is, organ donation is a very serious thing, and it is monitored by all the proper authorities as well as the medical board. This is the right time to
What is
take a
the
decision.
surety you are giving? What is the surety you are giving us that the organs will go to the right person?
Yes, all the organs that will be donated will reach the right people, and thus there are multiple authorities overseeing any transplant that happens.
Will it help a
Yeah.
lot of people, doctor?
I assure you, Mrs. Thomas, organ donation does help out a lot of people. One organ donation can save up to 8 lives.
What do you think, Daniel? Do you think this is what your father would have wanted? I think he would want to save people's lives.
Yeah, me too.
Is that your
Just
final decision?
let us know whatever we have to sign, and we will do the paperwork. And yeah,
Thank you so much, Mrs. Thomas. Thank you so much, Mr. Daniels. We understand how important and difficult this may be for you.
Thank you, doctor.
I will go and inform the proper authority.
yeah. Thank you.
That's how the scene closes with Mrs. Thomas and her son giving permission to the doctor to use the body for organ donation. Thank you for watching our role play.
Yes, so I'd like to point out again that after circulatory death, currently solid organ donation, though it's technically possible, the acceptance is not so much. You need a lot of infrastructure support for that. So in the case where you demonstrated, probably tissues could have been donated after you have declared him dead. But the future is DCD is coming. It is coming soon, maybe in 5 years, maybe 10 years. So in that scenario, you continue the CPR, then you give a hands-off period where no CPR, the CPR is stopped. Some countries make it 3 minutes, some countries make it 5 minutes, some countries make it 7 minutes. And after that, once there is a flat line, death is declared, the CPR is started again, the patient is put on ECMO, all the organs are supplied oxygenated blood. And there is a way to put in the ECMO. The brain supply is cut off by putting a balloon in the aorta so that the brain doesn't get a supply. And it is a process. You can read it. There's plenty of information available. And as I said, in the UK, in the US, nearly 40% of the donation activity is now DCD. So this is the future, but in the scenario you demonstrated, probably only tissues could be taken. Yeah. Okay. That is very well done. So
Thank you so much,
congratulations
ma'am.
to all the 3 teams.
Thank you, ma'am.
Thank you so much, ma'am, for your insights. We now move on. We invite Prajita Verma, ma'am, Chief Operator Officer of Organ India, to introduce the participants about transplant games.
On mute. Thank you so much. Am I audible?
Yes, ma'am.
Okay. I think it was very enriching to have this webinar. I'm sure you guys are the better people to give us the feedback, how you felt about the whole thing. We've spoken about transplantation over last 2 days, and we've spoken about survival, recovery, medicine, surgery. I'm going to talk something about what happens after a successful transplant. Can a recipient return to an active, fulfilling life? The transplant games are a powerful answer to this question. The World Transplant Games began in 1978 in UK with around 99 transplant recipients from merely 5 countries. Today, the World Transplant Games Federation brings together transplant players from over 60 countries every 2 years. And these games have sports like athletics, swimming, cycling, badminton, tennis, so many other sports as well. These games are much more than a sporting event. They celebrate life after transplantation, encourage physical rehabilitation and well-being, and create awareness about the importance of organ donation. When it comes to India's scenario, India is also developing its transplant sports movement. A lot of work has been done, is happening in the back end. Events such as Roto PGI MER Transplant Games, which has brought together hundreds of transplant recipients and donors from across the country. Indian transplant athletes are also increasingly participating in international competitions. There are Petang competitions happening, in Thailand, Bangkok. I'm also very proud to tell you that Organ India has been successfully serving as the team manager for Team India for the last 3 editions of the World Transplant Games. In 2025, World Transplant Games 2025 in Dresden, Germany, we took a team of 57 Indian transplant athletes across the country. They participated and returned with 63 medals across various sporting disciplines for the country, which is, I think, a huge success, a platform where we've proven that life is possible after transplant. And participating at such kind of a platform itself is very, very encouraging for the transplant community. For people who are especially working in the field of organ donation, the games help us tell the other side of the transplant story. We often speak about patients waiting for organs, lives that can be saved through donation. Transplant games actually show us what happens when that life is actually given a second chance. People return to sport, work, family, and their ambitions. And I would also like to mention here that for medical students, I think this is an important perspective. A transplant recipient is not just a patient who survived. They are someone who has been given an opportunity to live again. And behind every such opportunity is an organ donation. Thank you. With this, we are coming to an end for this webinar. If anybody has any question or would you like to add anything, Pujita, maybe you like to ask the group.
Yes, ma'am. The floor is open for questions. You can unmute yourself and ask the questions, or you can drop the message in the chat box. Do we have any questions? Meanwhile, there's a post-event form sent in the chat box. You can fill the form to be eligible for the certification. And the link will not be sent in the WhatsApp group. as only the participants who have attended and have 80% of the attendance will be eligible.
Pooja,
So
I
do we-
can't able to access the chat box.
Is anyone
Can
else
you
able
able
to access?
to can you able to put it on the screen? It's better, I think so.
We will get back to you. Do we have any questions, guys? The floor is open for questions for next 2 minutes.
I don't think there are any questions. You can move on to your whatever you need to do.
So yes, as we don't have any questions, we move forward. We would like to thank each one of you, each one of the faculty members who have taken their time and effort and trained us with all the valuable insights and trained us about the organ donation for the complete 2 days. And we are completely very grateful to Organ India for giving us the opportunity and collaborating with MSCI SCOF. Thank you so much.
Thank you so much.
Thank you, and thank you all for joining.
Also, guys, do fill the post-event form to be eligible for the certification. And if anyone is not able to access it, just send us a WhatsApp message. We will get back to you. Guys, you can leave the meeting. The meeting has officially ended.